Hello everyone, I'm Dr. Kim Se-jin. This is the case discussion to discuss clinical difficulties. We have clinical masters, Professor Yang Seong-min, Dr. Sun Young-hui, and Dr. Park Jong Hyun. Hello. Before we talk about the case under discussion, if you are watching the dental site in real time, if you have any questions or things to share, please use the chatting window on the right-hand side of the player. Now, let's go into the case to discuss. This is the patient information, 45-year-old male. Chief complaint is to place implants. There is no PMH. At number 26 and 27, implants will be placed. Number 36 and 37 are treated, and is it okay to place the implant at the bone level? Number 36 and 37 have short clinical crowns. Is it okay to do the crown after the pulp treatment? Do I need to intrude them orthodontically? Or do I need to reduce the maxilla to secure the interjaw space? There is lack of interjaw space to place implants. What do you think, doctors? I frequently encounter such a case clinically. For various reasons, restoration cannot be delivered right after the extraction due to the reasons of patients and doctors. That problem can occur. This problem occurs very easily, but resolving the problem is not so easy. So this is a frequently occurring case in our hospital. When time has passed after the extraction to treat the site, we usually use Omnivac to prevent the extrusion in that site. I don't know how long it can last, but anyway, you need to discuss the matter with the patient and do the restoration soon. Prevention is the best. Any other comments? Extrusion occurred. As Professor Yang said, it cannot be easily controlled, especially when you're a practitioner. If the treatment takes such a long time and if it is costly, patients do not like it in many cases. So the most important thing is that we need to prevent that from happening by delivering implant or other treatment. I will explain with my case regarding this. In my view, there are so many cases where the space is short. There are two things we need to do. We need to find the cause of the lack of space. First, VD is lost, so the space is short. And then the second one is without loss of VD. The extrusion of opposing teeth made the space short. So we need to identify the cause of the problem, and if it is because of the extrusion, without reducing the opposing teeth, the problem will occur. I hope the audience is thinking about this case while you're watching. If you have good comment, please share that with us on the real-time chatting. So, Master Doctors, how would you deal with the situation in a similar case? I would like to invite Dr. Sun Young-hui first. Usually, I believe you would encounter this kind of case quite frequently. In this case, we need to make a decision based on the volume of extrusion. As Dr. Park said, loss of VD. When multiple teeth are extracted, I believe that can happen. If the tooth are extruded in one specific area and VD is short, the occlusal plane is not fitting very well. So I'm a practitioner, as I said multiple times. There can be many different treatment options, but for us, the options are limited. In my case, when extrusion occurs or VD is lost, I do something like this. In this patient, number 37 is missing, and quite some time is passed since extraction. As you can see, number 27 is extruded, so a step is made in the occlusal plane. It's simple, and I believe other doctors are doing the same. The implant would be placed, and while we wait, usually for 8 weeks, and the treatment is delivered, the tooth is reduced and occlusal plane is aligned with a crown. So implant prosthesis delivered in the mandible. This is the most common option. There are other options, orthodontic intrusion or others, but personally, I don't really do the ortho treatment very well. Of course, I tried to treat it several times, but the result was not very good, and the crown had to be made for the patient again. So that's how I do it. When a single tooth is lost, the prosthesis is finished like this, and the treatment was finished. The second case, the patient had some story. So the first visit was in May 2013. As you can see, there was something strange in the mandible, and the patient wanted implant. Number 6 and 7 in the maxilla already had extruded. So it was rather strange. Therefore, I had to refer the patient to a university hospital. The diagnosis was ossifying fibroma, and the patient received surgery for that. And what I did was the endo treatment for 33, 4, and 5. And in August 2015, without recurrence, it was stabilized. So the patient came to me again for implant placement. Extrusion progressed. Number 4 had digital bone loss, so we decided to extract that, and implants were placed in 34, 5, and 6. As you can see, the vertical dimension is not that short, so it is deceiving. 26 and 7, the endo treatment is done in advance, and the healing abutment cannot be mounted. So VD was adjusted before surgery. Healing abutments could not be mounted in that occlusion, so VD was pretty low. In that case, in advance, endo treatment can be done in most cases. The second option would be placing implants a little bit deeper. In the lower, alveoloplasty can be an option, but all of them needs the reduction of normal tissues, so we need to decide very carefully. Implants were placed, and in advance, the endo treatment was done, and the implants were placed. It was finished in October 2015. In January 2016, the prosthesis was delivered, and upper 26 and 27 received the crowns. Before finishing the case, this is the most commonly used treatment option by practitioners who have private offices. Of course, if it is a single tooth elongation, ortho intrusion can be considered. However, in a case like this with multiple teeth elongation, this method would save time, and occlusal and chewing force can be recovered. This may be a better option. So this is the option that I use quite frequently. For example, frequently we have to extract lower number 7, and I do the splinting in the opposing number 6 and 7 while waiting. In April 2020, the last follow-up, and implants were maintained. This is how I treat a very general treatment. Thank you very much. Next, I'd like to invite Professor Yang Seong-min to talk. Thank you. In many cases, I agree with Dr. Son Young-hee. Looking at this case, let me explain. The first visit was in 2007. At that time, number 47 was lost and the opposing tooth is extruded. One thing interesting is that if you look at the other side, implants are placed and all the upper teeth are endo-treated. I think this is the option chosen by many dentists because, as was mentioned, it is fast, accurate, and something we can do. So everybody does this. When a patient comes, I explain the treatment options, and the patient didn't come for a while and came back in 2015. Compared to the initial extrusion, and the extrusion didn't progress that much since, and the opposite side is very well maintained. And I told the patient we can do this in the opposite side exactly the same way. Or if the patient doesn't want tooth reduction, we can intrude it. And I give the options to the patient. I should not ask the question, but usually they choose something not really appropriate, the best one. As Dr. Son said, I did not major in orthodontics, and I tend to go through trials and errors, and it doesn't go very fast, so I talk with the patient. In this case, the intrusion is observed, and after the start of the treatment, almost a year should pass before we see it is going up. It looks like it went up very much, but our teeth are three-dimensional. More force was applied to the buccal side than the palatal side. So one side goes up more than the other side, which is a dilemma. So a little bit of enamelloplasty may be required. In conclusion, actually, the treatment went pretty well, as we wanted and intended, but it required a lot of time, very long time. In the follow-up, no issues were observed. The patient chose that option. So we already explained it. It takes a long time. So looking back, there is no tooth reduction and minor enamelloplasty was done according to the prosthodontist in the opposing teeth. This is pretty good result in the long term. In the lower, the same case may occur. Fortunately, in this case, the situation was like this, left and right. In quadrant 3, the occlusal plane has some differences on the opposing side. The patient chose this approach and placed implants in a standard way. And the patient experienced this. And the routine follow-up went well. And the patient thought about the other side and wanted the treatment there. We talked about it for a long time. And the treatment is not necessary, so the patient wanted the other side treatment. On the other side, quadrant 3, if we can use the implants there, we can do it more easily. So time resolved everything. Over time, the occlusal vertical dimension was secured, and implants can be placed. You may say so. I think that can be done, but it was not easy, simple. So in my case, I did everything. Now, orthodontic intrusion can be a better option. As Dr. Son mentioned before, in this case, the opposing teeth are clearly extruded after the extraction. I took the picture on the day, so it is already extruded, and if the occlusal VD is not good enough, I do the bone reduction to secure the occlusal VD for minimal prosthesis. In that case, on the most right side, and if you look at the lower, the prosthesis is mounted, and a little bit of enameloplasty was done by prosthodontist. Occlusal adjustment was done and it was finished. In the upper, the same treatment can be considered as mentioned before. At a site where you plan to place an implant, if you can secure the minimal occlusal vertical dimension for the prosthesis through the bone reduction without taking such a long time as before, sufficient space can be created for the prosthesis. So in my case, as Dr. Son said, simply endo ICT or sometimes a CLP can be done. I think that can be the options, and for others, we can do the tooth intrusion collaborating with other department. In some special cases, bone reduction can be done to secure the height of prosthesis. So many different methods are used. Let me ask a very basic question. I'm not skilled at orthodontics. After ortho treatment, space was secured, and then the implant restoration. The cases came to me after receiving such treatment in other dental clinics, and I find the contact is rather weak in that case when the teeth are intruded, and the patient had more food retention problem on the intruded teeth rather than the implants. In other cases, maybe relaxation or for other reasons, the intruded teeth opposed to the implants had PDL widening. So I don't try ortho intrusion for extruded teeth. Have you seen such cases? Not a great problem, but if you look at the opposite side, the crown was done again. As you said before, sometimes we finish like that, but because of the contact problem or contour problem, in many cases, the crowns are made anew. It is the decision made by the prosthodontist. In most cases, all the crown is not used again. As Dr. Son Young-hui said, this is the fastest and accurate one. Intrusion takes a lot of efforts, but the cases don't look better than the endo crown cases. Maybe if you do the intrusion better, then it can be okay. Anyway, let me explain what I have prepared. The intrusion space is very short because of the extrusion. In that case, when the space is short, screw type was the choice. So internal conical type was placed and was splinted like this for the prosthesis. It was a very brave choice, come to think of it now. But when torque is applied, can an abutment be tightly connected to the internal part of the implant? I don't think so. Can we get the conical seal from the splinted prosthesis with the internal type? I don't think so. If one side is tightened, the other side can be raised. After 30 months, the bone response does not look stable. Still, we have the chance and the bone loss has not occurred, and the bone response is somewhat different. Soft tissue has some inflammation. Prosthesis is removed. At one side, the torque is remaining. The other side, the screw loosening occurred. The cotton is severely contaminated in the distal side, but in the frontal side, the cotton was rather clean because of the sealing. At the arrow, you can see the line contact is achieved instead of surface contact in both implants, so passive fit was not achieved. Therefore, prosthesis was fabricated again, of course, for free because it was my fault. The ER type was fabricated and delivered. At the 7-year recall after the final prosthesis, it looks stable and gingival response looks good. If I kept the prosthesis from 2013, I believe problems might have occurred like abutment or screw fracture or bone loss. No matter how narrow the space may be, the consecutive single cases can be using the screw type. However, splinted implant level screw type should be avoided. How much do we need to reduce? Reducing all of it is good. I want to do endocrown like Dr. Son, but many patients do not want it. They want minimal reduction. Dr. Kim Se-jin, what do you do in this case when the patient wants the minimal reduction and doesn't want the crown? I try to explain to the patient the necessity of occlusal adjustment. If they do not want the crown, I always align the marginal ridge. I think like this, in this state, if prosthesis is delivered, the food retention would be a big problem. So at least the contact points need to be exposed. The opposing tooth is reduced, but if the patient doesn't want endo treatment, we have to expose the interdental contact points so that it doesn't get hidden behind the opposing tooth. If the contact point is below the maximum contour up to the concave part by adding contact, it cannot solve the problem, and at least this much reduction should be made. In this patient, doing the crown, actually if you look at the prognosis of the opposing teeth, it's not good. To expose the contact point, it is beveled, and this is the minimal reduction amount. To increase the retention of the abutment, groove box and sandblasting are used. To do restoration in a minimal space, metal prosthesis is chosen. In this case, I reduce the thickness of the metal prosthesis up to 0.5 millimeters. So I tell the lab the thickness should be 0.5 millimeters. If further adjustment is necessary in the opposing teeth, I will do it. So I don't have to do any adjustments any further. With the minimal reduction, the prosthesis was fabricated and the patient comes to the clinic and it is very well maintained. Let me skip over this. I agree that endocrown is the easiest part, and this is very difficult. There's wearing in the opposing teeth. There's no evidence that VD is lost in this case. Reducing a lot of opposing teeth is not easy. Already enamel is worn out. In this case, I place the implants deeper to get more space, and I cannot afford not to reduce the opposing teeth, so I acquire as much space that I can get, and the margin is made subgingivally, and the abutment is shortened using the tapering groove and sandblasting. Gold prosthesis is selected to restore with a minimal space. When I restore like this, I've never had any cement wash problems. I make efforts not to create the problem, like I use resin cement that has the best retentive power. So this is how I resolve the problem. After 3 years and 3 months, prosthesis is not fallen out, it is maintained. And this case is very challenging. the patient heard from a university hospital that the maxillary bone should be raised with a general anesthesia. And after that, he came to me. So I recommended a compromising treatment rather than going through that surgery. In this patient, I decided not to raise the vertical dimension because the patient has very beautiful interior guidance still. The patient's original anterior guidance cannot be created with a newly fabricated prosthesis. The university hospital, when they said maxillary bone should be raised, I believe that's an option because the patient's alveolar bone is lowered quite a lot. However, the patient's beautiful anterior guidance cannot be given up, so I decided to restore, making some space. The occlusal surface is not good, but the patient doesn't have any chewing problem, and there's no problem until now after 7 years. So whether I need to raise the VD or not, the criteria is if the anterior guidance is such that opening the posterior region is made, then I don't have to raise VD. Of course, it's worn down more and angular cheilitis can occur, which I don't think will happen in this case. And this is the minimal condition to maintain the minimal VD. When the space for prosthesis is not sufficient, what we can choose is the subgingival margin. If you set the margin subgingivally, it is difficult to sit the prosthesis. To increase the retentive power, we can place it deeper, and the retentive area of subgingival margin lowered. However, soft tissue may be a concern, so we need to check the sitting and marginal ridge height of the adjacent tooth, relation to the opposing tooth, and check the x-ray if necessary, and we need to make sure it is seated properly. In this case, I want to emphasize that there were crown in the opposing tooth, and I did the prosthesis leaving it as it is, and the patient would not understand if I tell the patient it should be done again. But the conclusion is if I do not do what is necessary, problems eventually may occur. For 4 years, nothing happened, but recently the patient complains the discomfort in the gingiva, and I took out the prosthesis and I find the soft tissue seal is broken a little bit, minor gingivitis. I wanted the patient to live with it, but the patient complained the discomfort, so I chose what I can do. To resolve the problem, I used authentic titanium rod to fabricate up to crown as screw type. As titanium is friendly with the soft tissue, I thought it would solve the problem, but food retention occurred and soft tissue seal was broken. And I did the crown again. The patient could not understand the problem, so regrettably, I had to provide the opposing teeth crown for free. Authentic rod product was used to mill up the crown as screw type. There's a big difference. The crown has gotten longer. Opposing tooth is made again, so the crown has gotten longer. What impact does it have? It has this effect. The trans soft tissue part has become small. If trans soft tissue part of an abutment is small, soft tissue can get thicker. If crown or abutment has a large trans soft tissue part, the sealing becomes a bit weak. As you can see, this is the diameter of the trans soft tissue part. The opposing tooth is reduced and crown length is secured. The diameter of the trans soft tissue part is reduced. After 5 months of new prosthesis, soft tissue looks good and the problem seems to be resolved. However, This is the titanium occlusal surface using a rod. After 5 months, you can see a lot of wearing. So this type of prosthesis needs to be approached with care. I don't know about any exceptions. Because of the question, I brought this picture. When the crown is short, how can we increase the retention? I tried not to do crown lengthening because crown lengthening can cause the bone loss of the bifurcation of molars, which is fatal. So for endo-treated tooth, I make deeper grooves. With deeper grooves, stability can be obtained and retention can be acquired to a degree necessary. Summary, the question: do I need to place an implant on the current bone level after treating number 36 and 37? That is the question we received. I believe the marginal gingiva, the soft tissue, should be at least 4 to 5 millimeters. We need to place the implants deep enough to acquire that. Unless the maxilla is lowered, the bone reduction is not really necessary. When clinical crowns are short at number 36 and 37, for restoration, box and groove can be utilized, and when retention is short, resin cement can be utilized. If gold or metal prosthesis, the non-light transmitting prosthesis, it is important to use self-curing resin. Next question is, should I place an implant after reducing the maxilla to get an intrajaw space? As I said before, regarding the bone reduction, if alveolar bone is lower than the surrounding bone, sometimes tooth extrusion may bring down the bone at times. If it is not the case, I don't do a lot of bone reduction. As much as possible, I place deeper and I try to use other methods than bone reduction. Thank you. Thank you. 3 doctors gave us various explanations for this case. Let's go back to the question. And would you summarize based on what have been discussed? In my case, whatever the approach may be, I believe the dentist can achieve whatever the goal may be. For fast treatment, reduction of bone can be used. If you just want to change the positions of teeth, we need to use the orthodontic power. Dr. Park Jong Hyun already talked about various cases. What I am wondering about is we have a prosthodontist, but as a clinician, how much occlusal reduction can be allowed for extruded teeth? Maybe it depends on case by case. In this case, when I looked at the model, it is raised quite a lot. As Dr. Park Jong Hyun said before, if we have to reduce to expose the occlusal contact point up to the marginal ridge of adjacent teeth, we have to do a lot of reduction and do the crown again. If we don't do the endo treatment, it's good, but otherwise we have to make the crown again. Using the ortho power, if the tooth needs to be intruded, we need to tell the patient it will take 6 months to 1 year in advance. In this case, restorative treatment has been already done to the teeth, so the teeth are damaged to a certain degree. For the intact teeth, the ortho treatment can be considered, but here, the treatment has already been done to the teeth, and if we need to do the crown again, reducing the teeth would be a faster option. Thank you for the comment. Dr. Son, representing practitioners having private clinic, I brought aggressive treatment in the posterior of upper or lower when the interjaw space is short. As Dr. Park and Professor Yang said, the biggest problem is food retention, and because of that, we suffer as well as the patients. So if you're very skilled, like Dr. Park, various options can be used, but in my case, I majored in surgery, so I don't believe I'm very good in other areas. So I try to make the ideal condition. Occlusal adjustment is not something I really do. I persuade the patient that I need to accurately decide the positions and everything before I start the treatment. Long-term stability is the most important thing for implanted treatment. So I try to create the ideal condition before I proceed with the treatment for better outcome. Of course, as suggested by Dr. Park, the treatment option is not a bad alternative. I'm just scared of doing the treatment. Thank you. I've talked about various things. I showed you the past cases recently, and in the future, I will do the option used by Dr. Song. Thank you very much. So if I may summarize what has been discussed, three doctors all agree that prevention is the most important thing. Professor Yang Seung-min said, if conditions are met, ortho treatment or bone reduction at the surgical site can be considered, and Dr. Song talked about endocrown as priority, and Dr. Park Jong Hyun said minimal reduction of opposing teeth can be considered, or implants can be placed deeper, submarginal abutment, and the controlling taper using groove and box, and sandblasting is used, metal crown is used, and if natural tooth crown is short, box and groove can be utilized. But the conclusion is, so in this case discussion, we talked about interarch space. Thank you very much to the dentist who sent us this case, and I would like to thank the three doctors who gave us very good comments. This concludes the case discussion of today. I am Dr. Kim Se-jin, the MC of the program. I'll come back next time. Thank you.